the last session, we heard how digital technologies and other advanced technologies can be leveraged in the public health infrastructure, and what public and private partners both can do to achieve this, the aim of Viksit Bharat, specifically in the domain of public health infrastructure. Along with promoting efforts to develop digital technologies in health infrastructure, it is equally important to prioritize patient needs, as some of our speakers also mentioned it in the previous inaugural session. So, in order to understand and explore and learn about innovative strategies, tools, and best practices that can help healthcare professionals deliver exceptional care to the patients, we would now head with our next panel discussion on improving patient experience and operational efficiency of hospitals, challenges and opportunities. For this, I would like to invite Upasana Arora, Managing Director, Yashoda Super Speciality Hospitals. Please welcome her with a big round of applause. Saurabh Gupta, Regional Chief Operating Officer, KIMS. Dr. Kousar A. Shah, Executive Vice President and Zonal Head, Max Healthcare. Dr. Mamta Jain, Chief Operating Officer, Shree Aggarsain International Hospital. And Dr. Samir Singh, VP Clinical Services, CK Birla Healthcare. I would request everyone to please give a big round of applause for all our esteemed panelists here. Thank you, everyone. I would now like to invite Mr. Rajneesh to come on the stage and moderate the session.
Thanks. Our first panel discussion of the day is on improving patient experience and operational efficiency of hospitals. See, ultimately, whatever technology or infrastructure we talk about from the hospital perspective, from a healthcare perspective, any best outcome of this sector is defined by the quality of patient care and whether ultimately that quality of patient care has helped in recovery of the patients. So for every hospital, patient care and improving the quality and the parameters by which patient care is measured is extremely critical. So is the operational efficiency of a hospital intrinsically tied up to that. So we have a very eminent set of panelists from leading hospitals across the country and the region who will talk about some of these parameters, these measures, what are already being achieved and what are being done, and most importantly, going forward, what are the steps that they are undertaking in their specific hospitals, as well as the best practices the overall healthcare sector should follow. So let's start with Upasana first. What I would like to start with is one, from an hospital operation perspective, couple of best practices that either you are following or which you feel all hospitals should follow. And when we are talking about these best practices, let's say operational efficiency goes hand to hand in today's era with sustainability and in terms of being cost effective also. So what, according to you, would be a couple of those best practices that you would like to share? Yeah.
Good morning, everyone. And thanks to APAC News who gave us this opportunity. I am sitting with all my friends here. So best practices, if you see, everybody is, if a hospital is a good hospital, renowned hospital, and NABH accredited hospital, so they are actually into good practices, but who has adopted technology? This is a big question. Because we are digitally accredited hospital, we have adopted NABH digital standards also, and we have got certification of platinum level. So with this, things are more easy. Operations are more easy for our clinician, our staff, for me who is sitting on a room all the time, because I am also on shop floor, but it's not every day. It's basically why it is good, because now I know how much energy saving we are doing, how much biomedical waste we are generating. And by the way, we have received an award for biomedical waste also in SOCHM, because we are managing all these things. Because hospital is already providing lots of problems in environment, so we cannot stop everything, but at least we can you know contribute something to environment. So I am basically working more on ESG. So that is why my hospital is a green hospital. We have received a certificate from Bureau Veritas, as well as we have received an award from an AHPI. So these are the things which we are doing. And not only this, there are many other things like how to save water. Because when you go for green hospital, you are supposed to do all these things. And for that, we are putting lots of visuals. So everybody, not only my staff, somebody who is coming to my hospital, he should be part of our this program. And not only this, he has to spread this news to their homes, their friends, that they are also supposed to contribute something. So that is how we are. I am not talking about patients, because our hospital is a patient safety, famous for patient safety, because my core area is patient safety. So with patient safety, we are supposed to save environment also. So this is our mantra.
Okay, thanks. So, summing it up, two areas that you focused on: one, the need of standardization, the regulatory standards conforming to those are very critical for hospitals, and two is obviously the ESG standards that you follow. And being a green hospital, that's very laudable, and that I am sure all hospitals should try and emulate increasingly further in the future. I'd next come to you, Saurabh. Almost the same question in terms of the best practices for making an operationally efficient hospital, which you would like to highlight, keeping in mind sustainability and cost benefit. Uh, what would you highlight?
So good afternoon. This is Saurabh Gupta. First of all, thank you, APAC, for having me here. Now, let me just touch upon operational efficiency. So what is operational efficiency? There are so many definitions and people talk about just financial KPIs. But operational efficiency for me or for KIMS is actually doing things in a better fashion than they were being done yesterday. So every day the bar is changing, the standards are changing. And we believe in that. That's why we actually have a peer comparison mechanism, and we actually revisit our KPIs from time to time. So one best practice, as I said, is actually revisiting the KPIs from time to time. Now, when it comes to sustainability or operational efficiency, I will club both of them. There are three buckets in which you can actually see. One is what operational efficient parameters, which are also environmental sustainable, you can do at the time of construction. The second thing is your operational practice. And the third, and actually the most important, is your behavior change. Because, again, if you do not train your staff to do things, small things like switch off the lights and, do less of wastage, which is basically plastic waste and all, everything will go for a toss. So let's talk about the first thing. At the time of construction, now we're trying to actually use eco-friendly materials, and some of the hospitals are going into LEED certification. Actually, Dr. Rajiv Singhal is not there, but the first Indian green hospital is from Marengo. So they have used a lot of, reused material, and that practice is very common. The second thing is, see, India has a vast geography, and what materials are being used in Delhi is very different from Chennai, from Bombay. The use of glass has increased, but there are places where glass does not make sense. It, increases the use of air conditioning. Again, there are multiple things. Even the type of chemicals you use to clean glass actually are not very environment friendly. So we are trying to, limit the use of glass, go for traditional materials, and we have created few areas which are naturally ventilated, like the patient cafeterias, patient attendant cafeterias at the rooftop and all, we have kept in natural ventilation. And so there is a drip, cooling mechanism which we are using in many of our hospitals, which maintains, temperature around 24 to 26. It's not an air conditioning, but it's very much environmental efficient. So there are, and 3 of our hospitals, we have around 16 hospitals now in India. 3 of our hospitals have gone for this captive solar generation, which actually you can generate at, you can tie up with many agencies, you can generate the solar power at other place and you can transfer it to your hospital. So we have gone on construction. On operational things, actually, we run a lot of plastic-free hospitals. We don't print any films. We use packs. We use we have a KIMS doctor app. Everything can be seen in there. And if required, we actually use medical grade paper. We have tie-up with Canon. We use that and we give films. So that is one. We, again, do not use any plastic bottles. We have a refilling plant. So this is what you will get in majority of our hospitals. We have done small things like, we try to reduce, as I say, plastics and even paper. So our X-ray cover, for example, come with the handles. So you do not need another bag. So you reduce 1 bag per patient. So small things we have done in our hospital. And there is a program which we do, which is known as APAI. It's a Telugu word, which is a patient experience program. And in patient experience, we actually also undertake training for a patient. We tell them how it is better from them and environment to reduce the use of plastics and other harmful chemicals. So I think to sum it up, 3 things: at the time of construction, operational, and regular staff and patient training and education.
Thank you. I like the first thing that you started with, that the operational parameters to just gauge whether they are effective or not. It's a very dynamic process. So it keeps on changing and the bar post keeps on moving. So you have to be dynamic also because the parameters are ever changing, and the innovations. I'll come to you in the next round with one of the innovation features. It's very good, the packs and non-usage of films and some of the stuff that you mentioned. But whether, as you rightly mentioned, India being such a heterogeneous country and patients are also coming from diverse backgrounds, whether how many of them have become so savvy to use everything digital. So how as a hospital you are looking? I'll come to you on that in the next round. I'll come to you, Dr. Kousar. Again, the same question in terms of operational efficiency, cost, sustainability, your recommendation, what you are doing, and what ideally the hospitals should be looking at doing.
Thank you and good afternoon. Can I just request everybody to do hands like this so that I'm sure everybody's awake? Thank you, because it's too dark to see everyone. So just on a lighter side starting. So I think a lot has already been shared by 2 of the eminent speakers. I recall a time when, I think around 12 years back, there were too many of such incidents. I'm just remembering one. So there was some DNB inspection which was to happen in my institute. So I called all the reports. Are we ready on that or not? So everything came to me, of course, as it used to be on a piece of paper with an Excel sheet made like a table or so. When I started doing the calculation, I understood there were some things which were not matching. And this was, as it used to be earlier, it was given to me by somebody like a GD or so who had come to me with the reports from the other side. So I asked him, this is not accurate. Can you just go back and get it checked by the people who have made this? There were 5-4 people who had made this. He said, okay, sir. Now he went back. And he came back as usual in those times, in about 3 hours' time. So 3 hours' time, I mean, of course I read many more things, but this particular thing which could have been closed in just about 15 or 20 minutes, it took me in totality to close that in about 4.5 hours. Compared to that, as of today, Today, when we see anything or when I have to review anything, I just have to open my laptop, click on the HIS, see whatever I can see, whatever I want to see, even historically. So I think that shift has been very, very practical for all of us and very advantageous as well. So in terms of the time which it used to be taking for people to be looking at various things, checking on the manual way and all has changed completely now. It all is available at just one click. So I think one thing which I would say that digitalization of operational parameters has been a big shift in the healthcare, yet there is a lot to be achieved because digitalization, just doing that much is not enough. Or even using the HIS, which most of the hospitals are using nowadays, is just not enough. We need to have all the reports coming to us as what it should be, plus the review of the report, analysis of the report, action points of the report is again paramount. So a system which can throw every single thing, right from the analysis to your actionable points. Now that's up to you. You want to take it up or not, that's a different thing. That is what is the right HIS or digitalization for hospital and healthcare. So now there are, products available which are doing all this. You just need to punch in the type of report that you want the system to be throwing to you, and it starts doing that on a specific regularization basis. One thing which we did very emphatically pretty well, and I'm just remembering this right now. In my hospital, the consumption of the films in radiology used to be in a ratio of around 25% on the app or maybe on the software copies. 75% used to be in hard copies. Now I picked that up as one of the projects to start, which was a new thing in fact. So I took a lot of training with the doctors, a lot of discussions with the doctor, and it was about an year back when we started this focus. As of today, the shift is totally reversed. 91% films are not being printed. It is all digitalized nowadays. Only just about 8 to 9% or maybe 10% at times is what is being printed. Now, in terms of the cost saving from that, anybody who can guess what we must be saving on a monthly basis? So we are saving on a monthly basis about 7 to 8 lakhs, which is a huge thing. Now that saving, if you multiply this into the months basis, it becomes even bigger in fact. So that is just one example which I am giving. But a lot of things are happening, like we are monitoring on the patient's consumption level. Like for example, what ideally should be given to a patient as a consumption. Of course, there is no control over it. We don't want to be, cut short or care being given to the patients. But what is rightly to be put, that is being put or not, because what we also realize when we do this discussion with the doctors, that the prime or the primary consultant will not be even aware what has been put to his or her own patient. Because a lot of things are happening at the second or third level, which is the entire team level. Maybe the RMO, maybe the senior resident, and the primary consultant may not be even aware about this. When this report is coming in a digitalized form, when it is being shared with the doctors, they are actually surprised to see this at times, and the course correction happens because they know what is really required for the patient. One big thing which again we started, which is paying us dividends in the last few months, is like our emergency patients footfall is pretty well, in fact, in my hospital. But what I realized, average billing of the patients was somewhere around, on an average, around 20 to 25,000 for a patient staying in emergency for just about 7 to 8 hours or maybe 5-6 hours. So again, I had a lot of discussion with the doctors. We came to a specific reporting mechanism where nowadays a digitalized report comes to the emergency team and of course to me as well and to my medical director, which speaks about any patient who has been billed beyond 10,000. And the doctors, like the senior most people, look at from clinical requirement perspective. So again, the same thing, which used to be like people in the night time putting whatever the things they want to put on the patients, has completely come to a only proper optimization from the usage of these resources basis. And our emergency footfall, specifically for the patients who are cash, has skyrocketed by about 45% because now they know that the shift has happened in terms of the overall average billing as well. So I think these are small steps which actually helps not only about the perspective of the patients, but also for the optimization of the cost, plus adding to the bottom line, plus of course to the top line as well.
Thank you. Thank you. So, uh, summing up two very important things you mentioned, obviously, the last one where emergency patients and the way the actions that you undertook, which resulted in that increase in emergency patient footfall, that's very innovative. And earlier you talked about, which question I'll put to you in the next round, when 91% of the reversal, this, but what I would like to understand is we're talking about digitization, the HIS, the EHRs, and the EMRs are there, we know, but how are you convincing all the stakeholders? I know even doctors now often they don't want to read the PDF, they want the actual report. So what how do you, it's, and it's not a sort of a issue which can happen through a diktat. It has to, they have to be convinced, the doctors and even the other concerned, the nurses and everyone, bringing them together. I'd like to put that to you in the next round. Now I'll come to Dr. Mamta Jain. Again, the same question in terms of the operational best practices as far as cost effectiveness, sustainability is concerned, and how are you looking at which improves the patient care overall?
Yeah. Good afternoon, everyone. And thanks, APAC, for having me here. And my colleagues already, they talked about the green hospital and the efficiency in the operations. I would like to touch upon the operational aspect in the OTs as well as in the laboratory services by just improving 2-3 things. Like, as the administrator management people, we always face in the OT that this patient was taken last, this patient was taken first, my patient should be first or last. So what we created in my present organization, I belong to Shree Aggarsain International Hospital. So the patient schedule will be given to the surgeon itself along with the anesthetist. They create the through the software, and they are everybody who posts the surgery according to their timings, and they have to stick to it. And there is a gap of only 12 minutes. If they come and take the patient, it's fine. Otherwise, next patient automatically will be taken in. So 3 OTs, 4 OTs, accordingly it will be open. And this is the operational on the day-to-day basis. But when the patient is admitted, because these days we are working on the ALOS, average length of stay. If the patient is staying more, they are occupying your hospital beds, which is again, your EBITDA goes down and obviously your operational efficiency go down as well. So the patient has to be admitted on the same day, because if he is admitted on the previous day, he is not going to pay. We are working on the packages, whether it is CGHS or whether it is TPA or cash patient even they don't want to stay more than that. They also expect some kind of package stuff. So if patient is admitting in the morning, we created the system process that a day before the list will be shared with the reception people. They are going to make a call and find out whether the amount was submitted online or in cash. So it is, the information goes almost 9:30 or 10 p.m. And when the patient is coming in the morning at 6 or 7 according to their schedule, and everything is done. File is prepared in the night, because if you take the consent from the patient, and when patient comes in the morning, he happily goes within half an hour to his respective place, whether through the ward or through the day area to the OT. It's very simple. We did nothing, just creating one chart through the HIS where the doctors are going to create their own schedule, and then rest of the things are coming automatically. The second thing was, in the laboratory services, we see that we are dealing with the technicians. And obviously, when you are dealing with the technicians, people come from the various backgrounds. You may expect everybody has to be honest. But pilferage is a thing which is very difficult to control. Even we say as an administrator management that 1 or 2% is admissible. I say there should not be 1 or 2% because that is the cost. So what I did, I said that we are going to run the samples on the cost per running. And it is all automated. the barcoded, and when the patient is giving sample, it is whether it is EWS, CGHS or anything, it is barcoded as well as the panel is mentioned, and then it goes to the laboratory services and it will be run, and whatever is coming that will be billed to the patient, to the company. So by doing this, believe me, we save 2 CR per year cost. 2 CR. Otherwise, that was a cost, or you can say sunk cost. So these two things were very important. And similarly, in similar fashion, the already Saurabh mentioned, by just switching to the pack.
Yeah.
Those costs were earlier nobody was acknowledging. And these days, everywhere you are saving cost just by optimizing your operations.
Okay,
Thank you.
thanks. So, two important facts that you mentioned are, and typical hospital operation, the external agencies, the TPAs or CGHS or the labs, the importance of labs perhaps was best emphasized during the COVID time, when even for moving, not just if you are a patient, but you have to fly, you have to get all those reports on time and RT-PCR and everything. So we all went through that. So I'll come to you again in the next round on the dynamics of this TPAs and CGHS, because that becomes an issue and creates a bottleneck in the operational efficiency. Before that, I'll come to Dr. Samir Singh. Uh, Again, the same question, the recommended best practices that you would like to mention about better operational efficiency, sustainability, being cost effective at the same time.
So, a very good afternoon to all of you. So, thank you for the question, and I think thank you for inviting us to give this opportunity. I wouldn't deviate much from what the leading speakers have already spoken, but I think I'll have a 3 mantra here, since this is a technology related scope which I have to speak on. Yes, we must invest into technology, we must invest into training, and we must also look at how to sustain this up. And I think with these 3, you would be able to ensure that there is a profitability, there's operational excellence, and that doesn't move you out of your core business principle, which is patient centricity. So I'll give you some examples from our clinical experiences, what we usually think is a cost saving initiative, but it actually helps great outcomes for patients. So something like investing into latest technologies, like I'm presently exploring a fumigation mechanism for my OTs. Now it sterilizes OT 10 times. It's an Italian company. Right now we are running a trial with it. It does it in 12 minutes. So my time between a dirty surgery and the cleaner surgery is better. Also don't get influenced with, I also come with a lot of, I think, experience with the NABH and auditing hospitals. So we all talk about modular OTs. It's only one type of OT. If you read, there are, type 100 SSOTs, which saves you about, say good 50 square feet per OT to do a super specialty OT. So I have a robotic OT, which is only 460 square feet, right? When we invested into robot, we thought it's just something fancy which my surgeons wish to have. But I realized what benefited out of it is hospitals in Haryana cannot have a blood storage unit. You can only either have a blood bank or a blood center, but you cannot have a storage unit. We are from a high-end surgery center. Our 80% cases are only surgeries, less of medical. There are times when we are, really pressed against requiring blood. So when we invested into robotic, we thought probably we'll break even after 1.5 years. I'm happy to share that we were probably be able to, reach that cost optimization in about 7 months, not just from the terms of volume. And I think 91% of cases, there was no requirement for blood at all. At about 79% of your patients who undergo these procedures, they will tell you on a scale of pain scoring, 0 pain on, surgery. Somebody spoke about ALOS here. So you mobilize patients on the first day itself. So we also started benchmarking our ALOS against specialty surgeries, using our MIS against each, the top 10 surgeries. So some of them you wouldn't have heard that there'll be bilateral TKR. You get admitted today at 7:30 in the morning, and tomorrow night before 12, if you're a cash patient, there's no insurance or a third payer, we'd be able to send you home. And that's where a technology comes into picture, that we started mixing spinal anesthesia with morphine. Now, spinal anesthesia requires a very constant monitoring. So do I just appoint another NSA to sit there or not? No. So that's where the tele-ICU or remote monitoring helps. So my HDU has a very focus where you could sit in your OT and the anesthetist could still monitor. So that's where your investment into these smaller technologies actually has a very quick return in your, meeting up these operational efficiencies, getting your beds out, making it free and safe, free for the next one, making it safe for the present patient. Invest into technologies like electronic medical records. Not from a medical legal angle, but things like if you have something called as an integration with SIMS, or a barcoding of all the medication ones. So when we were looking at barcoding, we thought it's to do with so that there's no pilferage, there's correct billing. But I looked at my data 2 days back. For 6 months where we have done this, we had 0 medication errors apart from prescription ones. If a doctor has written it incorrectly, that's something I cannot help it. Even that an alert comes from SIMS. Hey, your present medication is probably going to interact with so-and-so, right? But the administration, the dispensing one, that has come down to 0 in a 220-bedded, completely filled hospital. So I think these technologies also helps you, not just operational efficiencies, but deliver, great patient outcomes as well.
Okay, great. So this technology that you mentioned, which reduces the blood pilferage part and the use of robotics, I'll come to in the next round on a very basic question, the cost involved.
Yeah,
Yes.
I just want to add something. So it is very interesting, something which came actually. So what Kousar just spoke about and what Samir spoke about, the power of data digitization. So I think it is important to actually digitize, and we are talking about AI and ML. But what we have seen is that just going towards the digitization and putting AI without integrating it with your larger plan, without integrating it into steps, might not help. Actually, it is sometimes detrimental. One example which we saw, we are working on this. So there are a lot of parameters in HIS which are very powerful. You can really create heat maps. One very important data which you capture at the time of registration is the PIN code of the patient. Now this PIN code itself can do a lot of wonders. If you can integrate it in Power BI, it can throw so many things, where the patient is coming from, what type of acuity, you can marry it with so many things. Now 6 months back, we actually pulled out data from some of the hospitals, and we saw that 25-30% of the data is bogus, because it's a free text, anybody is writing anything. Now then we spoke to some of the people, and now we're trying to integrate AI to prohibit people to write anything, because it will actually pull data from actual PIN code, and not only PIN code, some of the important parameters it will match that time. So the correctness, what I'm trying to say is the data which is going in, because machine learning is what? Machine learning is actually pattern which you follow, and it picks up that. So until there's a data accuracy is there, it involves training and use of AI actually to input the correct data. That is very important. Then only you will actually have the desired result in terms of the report, which we have actually faced, because a lot of people are just putting in data which will not make any sense.
So no amount of analytics can give you proper insights if the source of the data itself is...
So I have a small itch.
Yeah.
Can I just...
Sure.
Okay. I mean, instigated by what Saurabh just said and what Samir just said. he mentioned a very, very valid point. Like most of the organizations nowadays are into HIS and using the systems and all. But the point is that we need to understand digitalization, computerization, or whatever is, in a way, you can say, is very attractive, it's very seductive. But if you do not use it appropriately, it is a huge cost for you. And Samir would vouch for it, and all of us are business heads basically here. Every year, when we make the budget or we finalize the budget for the next year, the cost of other things may be increasing by about 6 to 7%. IT is one cost which increased by about 45%, 55%, and thus inevitable. Now, I have been to some of the organizations where maybe I went to just to see the things and all. I understood that their HIS had about, for example, one organization had 105 reports available in the system. But what they were seeing was just 6 to 7. So those were the opportunities they were missing, yet the cost was huge. Now I'm through.
Exactly. Yes. Okay. Okay. Now let's come back to you, Upasana. What earlier you mentioned about some of the issues that becoming a green hospital, the standards that you are conforming to, and the recognition also that you have got. My question is, all of these comes at a cost, and that expense inevitably it's not possible for the hospital to absorb all the costs. At least partially, it needs to be passed on to the patient itself. And there is a dichotomy. How do you balance out the situation?
Very interesting question. And if you ever visited my hospital or somebody who has visited my hospital, they can vouch for me that Yashoda is the one hospital who is affordable. We are known for affordable prices and patient safeties for high-end technology, which is a very rare combination. Because if you are adopting new technology and you are investing lots of things in your hospital, then you have to have, money. But same time, because it's a family-driven hospital, me and my husband are running this whole chain of hospitals. So we understand, we both are from a very humble background. So we understand everybody is not having big pockets. So for that, our mantra is volume of patients. My hospital, our seminar hall, which was supposed to use for all the time some conferences or some meetings, still that is also booked for the patients. So in my hospital, and why patients are coming to my place? Sorry, Kousar is sitting here. We are surrounded by Max from all the sides. So still we are always full, and not for this dengue or fever or something like that. We are full for surgeries, we are full for cancer, we are full for everything, because we are providing best patient care, good outcome, and affordable prices. So we are not passing our cost to the patient, but same time we are trying to create an atmosphere. Somebody has to, there is a thing that who comes first, hen or egg? So I wanted to take that step. We are supposed to do good work for the society, and then society will give me back that I know. Because my journey is from last 34 years, we have started with 100-bedded hospital. So don't think that everything will be given to you by the patients. There are many things, reputation and other. My patient is my brand ambassador. He is sending me more patients. Thank you.
Welcome. That's great to understand. Next, I'll come to you, Saurabh. What I wanted to ask in the earlier round, when the digitalization of HIS, and you are talking about that all the constituents. So what were the challenges, and in sort of convincing them, how did you go out? Briefly, if you can mention that.
Okay, I think very pertinent question because actually it is, with all the due respect, very difficult to convince doctors. And I'm still trying to be there. So two types of challenges. One is on the hardware side, and one is on the software or the behavioral side. So of course there were challenges when you talk about technology. Every or not every, but majority of the machines are from different vendors. Some of them are old, some of them are compatible, some of them needs an interface. So there are a lot of technology challenges. We have like our own CRM, our own in-house developed app, but the HIS is Suvarna. So integrating all of those is a challenge. So sometimes interfaces do not work, the data does not get updated. So there are tech challenges which we are working upon, and up to a huge extent we have solved. But I think this is still doable. The major thing is how you convince doctors and the other stakeholders. So one thing, and I actually come from my previous organization was Medanta. So one thing which I learned from Medanta is I was running Medanta Lucknow, and Ognito is actually a very successful product which we co-developed. With Medanta co-developed with Ognito. So the success rate went up to 80, 98, 99%. So what happened is when they came to the hospital, they said, we would like to work with some doctors. And what happens is that whenever such people or any pilot or any company comes, you actually see who is available, who is the doctor who is available, who is not very, occupied, who has sometimes. But what we did is we actually found some of the doctors who were highly occupied. They were, people of repute in the society, and they had like brimming OPDs from morning to evening. And what we said is, why can't we actually talk to them and make them champions? Because if they are convinced and they run the project and they see that there is some benefit, then it will be a smooth walk. So to start with, it was very difficult to first of all convince. There is a Dr. Sharma who is a very renowned nephrologist. People in that region might know. He was actually the champion for the project. Okay. His OPD is more than 100 patients a day. And when he started, he told them so many things to actually modify. But when he saw that the software was working in his prescribed pattern and he can actually save time, it's to his benefit. Then he started telling other HODs and other doctors about this. And actually this worked like charm. In KIMS also, there are a lot of like the KIMS doctor app. It is actually very highly related doctor app. It was developed by a doctor in-house. It was not developed by an external agency. It was developed by a doctor, Dr. Sudhir, who is a gastroenterologist. He's a tech-savvy guy. He said, no, let me do something which is beneficial to doctors. So he got some resources from the CEO and started developing. Now it is, a flawless product, and it is rolled through across. But again, it is driven by doctors. So I think whatever you can drive through doctors, make them partners, that has worked very well in the organization, in my experience.
Okay, so basically you need a champion to evangelize the cause, if I may say. Kousar, what I would like to again understand is one, bringing together all these constituents and some of the innovations that you mentioned, the emergency, and what were the challenges there? It's not from a hospital of a proportion like Max. There must be operational challenges. How quickly, so that other hospitals can emulate some of those best practices?
I think to start with what Saurabh also just said, one of the most difficult things in any healthcare for any process to start, because healthcare is all about doctors, is to convince the doctors first. Now, doctors' conviction is one of the most toughest things because it's difficult. And I say this myself because I'm a doctor myself, so I know that I'm also not an easy thing to be handled. So I know how I can handle others. So the best ways, in my opinion, to convince a doctor is not in a boardroom, it is over a cup of coffee. Okay. Bring about the facts to them, and they will understand the most difficult messages to be given to them as informally. They will take it by both the hands. If you have done that, everything else starts falling in place. Okay. As Saurabh also said, so I basically use two strategies when I'm to convince a doctor. One is which he said, like, you catch hold of the one who is the biggest volume runner for you, which is definitely a big one. But at times, the one who's driving the larger volume is not the easy one to handle. So there I follow the other way around strategy, which is I do a bottoms up strategy. Now, for example, if there is a guy who's doing, let's say, about 35% of the volume he's driving or revenue he or she is driving, and is the largest one, but not the easy one to handle. So I want to basically make that person feel aloof. So I want to fill up the gap by aligning all other people, which is about 65%. When he or she will feel most of the organization people are aligned to this, I can't be left alone. So the shift starts happening. So as you spoke about what I have done about, like, for example, I spoke about the radiology part, the toughest one, because convincing a doctor that the film is not really required is not so easy. So I had the similar type of a strategy there. We started with the ones who are not so much volume drivers of the radiology, but still they were the drivers, because every doctor does this. Convincing them was easy. So from about 25%, it came up to a bit more, then it came up to a bit more. So finally, the topmost ones were left over, and they said, okay, I cannot do this 100% because, for example, somebody is an orthopedician, somebody is a neurologist or so. They do require the films for a specific reason. So they said, okay, leave us maybe less. If I have to do 100 films in a day, I will do about 15%, but the rest I'll still do on the, on the digitalized. Okay, I'm okay with that. So leaving alone that is still a healthy one, because for 25% of the usage of the films, going to about 90% is a big shift, in fact. So the 10% is something which we had to take a call, okay, let it be, because anyway we are shifting a lot from there. Similar thing about the emergency. So emergency, I would say, once you have convinced the doctors also, your systems giving you follow-ups as a process is extremely important. So you need to devise systems where you get the follow-ups, where you get the reports to you, and you get into the picture, or maybe with the right people who are given the responsibility to do the follow-up. That is to be done on a regular basis. If you do not do that, it doesn't happen.
Thanks. So
some of these meetings actually do not happen over coffee. They happen over single malt sessions.
so that was understood. So
No, I didn't say that purposefully, because I would be asking for this then.
okay. Next, Dr. Mamta, you earlier mentioned about the TPAs and the CGHs. Now, insurance and labs are two of the, and they're external agencies. So how do you streamline this? What were the challenges you faced while streamlining?
I'll tell you the example. You know, in India, insurance companies came through multinational. And for hospital to adopt, like every now and then, you see every hospital has the TPA and CGHS, and people are cost conscious as well. In 2008, way back when I was also working in some other organization, and we had very high volume of the patient every day. 80 patients are in, and at 80 patients are approximately getting discharged. So we had a meeting in the FICCI saying that everybody was cribbing about this problem, that every day you have to take the approval, then go for the treatment. And meanwhile, patients are, obviously they will shout that because once the approval will come, then only you can proceed. So everybody has the same problem. Then somebody said that who will bell the cat? I said, I have the maximum volume, let me do something. And I created, sitting in my hospital, created packages 43, which were rolled out all over India. And Aggarsain was the first hospital with those packages, with the highest packages. So it was not that tough. The thing was, behind that, what was the force? Force was because it is a pricking point that every day you have to take care of 160 patients in and out. And you have to provide the patient satisfaction, as well as you have to satisfy your consultant. You have to operationalize, optimize your operations as well, reducing the cost and patient satisfaction to the maximum. But what you need is just to create the packages. So those packages were created and rolled out, and the life became easier for everyone.
Okay.
And now talk about the CGHS. CGHS, by and large, we compare with the cash patients, the cost is quite low. I would say less than 60% of your cash patients. So you are working on the 40%. And there also you have to make your operational efficient, patient satisfaction, not to mention that these patients, because they do not have to income from their pocket, they do not want to get discharged, a loss may increase, your infection rate should be decreased, cross infection should not be there, which is not been paid. So all these things, until unless, it depends on the multifactorial. Until unless your operations are optimized, keeping in the mind that cost is a major factor which affects your patient ultimately, and as a head of the institution, you have to ensure the profitability also. So
Exactly.
not to give that cost further to your patient is the actually crux and leads to patient satisfaction. If you just shorten the cost as well as the time. So response time is very important.
Exactly.
In TPAs, because you have maximum patient, now 80% patients belongs to the TPA and everybody is having the insurance. So that also depends a day before. You know that this patient has to be discharged tomorrow, so you need to talk to the consultant. And those consultant, again, Saurabh also mentioned, Kousar also mentioned, it's not easy to handle them. Then you have to talk to them one-to-one. The doctor who is having maximum patient, if he has the 60% patient load. So you first deal with that doctor. So 60% your patients are satisfied. They are going well in time. Your bed is unoccupied and take the new patient.
Okay.
So talking, communication, reducing the time, that is very important.
So reducing the time is one very critical factor that you
and
mentioned.
then second is preparing the discharge summaries. That is called tentative discharge summaries. So whenever patient is admitted, he may take minimum 24 hours. So second day onwards, the tentative discharge summaries are to be read through your resident to your medical transcriptions.
Okay.
Then everything falls in place.
Thanks.
Yeah.
Dr. Samir, the earlier question in the earlier round that you mentioned about the things like robotics, and I'll put a similar question that comes at a cost. Now, how do you ensure that that entire cost is not passed on to the patient?
So while I do agree, yes, the technology comes at a cost, but not necessarily the entire cost has to be passed on to the patient, because some of them are intangible in terms of benefit, as all of them mentioned. It helps you draw more patients. So while we were probably the last ones to enter into robotics in a market like Gurgaon, where probably if a patient falls, he'll fall in front of a hospital which has a robotic, right? But then we also realized we were the first ones to cross the 100 mark, the first ones to cross surgeries in gynae, which, the largest number of fastest 60 surgeries. So we also realized first time my cost was about 1,30,000 rupees additional for a procedure, say maybe a hysterectomy, if it costs X, it will cost X plus 1.3. And in 5 months of time, across the 3 geographies where we operate, it has come down to 68 and 70,000 rupees as consumable cost. While the robotics company has another model. They were willing to give you on a rental for say 75 or 77,000 per case basis. So that's where we thought that no, our operational efficiencies are great. We'll be able to put a cap on the consumables, bring in a parity across, and we deliver that in 4 or 5 months across all specialties. And so we are looking every month, can I save another 3? And that benefit goes down to the patient. It eventually goes down. You also have to look at other possibilities, like how could you reprocess items, how could you re-sterilize and use them. That benefit, the proportionate benefit, goes down to the patients. So it's not, and some technologies cannot be built to the patient. Like what I'm doing, a fumigation and my CSSD, it's only to get my OT faster. So if you look in a way, if I was doing 8 surgeries, if I'm able to do 9 plus 1 more minor, it really compensates for that. And that's what we are studying and investing into.
So these are very innovative measures that you mentioned. So before we conclude, very quickly, 30 seconds to each panelist. And I'll ask you one efficiency measure that you see adoption happening in the future? 30 seconds to it, starting with you, Upasana.
First of all, efficiency you can see not in future, even if we see in the present also. How much your patient outcome is coming, how much safe your patient in your hospital, and what is your LOS. Both the things you can see, as well as everybody was talking about revenue and all. Because in my hospital, I am the one who is looking after, so I am not answerable to anyone, so I have never seen all this. So, but two things are very important, like your patient outcome, how is satisfied, and how in a short period of time you are able to discharge your patient without any complication. So for me, success means your happy patient.
Okay. That's ultimately.
Yeah, who is
Yes.
next?
Saurabh, 30 seconds to
Same question?
same question. The
So,
future, just looking into the future.
I think it cannot be one parameter, first of all. It will be a weighted average of three things. One will be your financial metrics, which is all your revenues, bottom line. And again, nowadays we are seeing so much investment, so, return on capital and all. So that will be one. The second thing is, I agree actually with Upasana, that it will be the patient experience parameter, because what is happening is, with the clinical precision coming, because the type of technology which we have, the difference between A and B hospital is actually reducing. So, primarily it is all about patient experience and clinical outcomes. Clinical outcomes, again, are being driven to some extent by the use of technology, which will increase. The human intervention will reduce in the near future. So I think it is actually a weighted average of the patient outcome, patient satisfaction, and the financial metrics.
Okay, thanks. Kousar.
So my take is not just about the main course of the hospital, it's more of a back end effect, but which has an impact on overall everything included, because that's going to impact the employee satisfaction. So my point is automation of HR is going to be a big thing, in fact. And the implementation of automation of HR and the HR related processes is far easier, because it doesn't require a stakeholder like a doctor or maybe a clinician or a nurse or so. It's just the time when the people are getting into the system, and from the very moment if they are given that carpet, that you need to only walk through like this only, which basically makes their life easy. And their mindset also becomes pretty tuned towards this organization is digital savvy, so we need to be working towards it. So that eases out the persons joining into the system. I mean, the entire thing, if that gets digitalized right from the application to the interview organization, plus a big thing which is currently missing is what happened after the interview. So somebody who is not selected, that person keeps on waiting for something also, or something or the other to be coming to the person, or the person has to inquire about it. I mean, himself or herself. So imagine the HR throws away a report to the HR of the specific place that so and so person was interviewed, let's say 30 days back. The result is due to be spoken to the person. So these are a few things which I will say that will be making a huge amount of impact. Plus the ongoing employees engagement, which are already in the system. This will create happy employees with you. They'll be more engaged. That will create the best of the patients and the clinical results plus the patient experience for you.
Okay, so the internal employee engagement leading to better patient engagement, if I may say. Okay, Mamta, your 30 seconds.
Yeah. I want to focus on the automation of OPD, because your face of the hospital depends on three things: the emergency, how you run efficiently your emergencies, your reception, and the OPD. In OPD, everybody, I don't know how come the patients are going up and up every day, whether the patients are not conscious or the society is not conscious about the health. But your OPDs numbers are going up. In every OPD, if you doctor has to see the OPD, then IPD rounds and the OTs, and patient satisfaction in the OPD, if there are queues, how do you handle it? So the answer is automation and the digitization, HIS, which is EMR, OPD EMR. So what we did, because the patients are numbers are very high, nobody wants to Just they want that we are a tip of the pan is this, we want to go for this, we do not want to use the computer because it is going to take much more time. I said, no, let's do the exercise, just pilot project in one OPD and see how the outcomes are going to be. And you will be surprised, we created the templates for each OPD customized to their specialty. Whatever is their tip of the pan, whatever they write, and everything was coming automatically, and they were so happy. The lab reports were coming, and when the patient was discharged, when patient was coming, how many times it came. I mean, you don't have to flip. You don't have to take those dirty leaflets in your hand. Maybe microbes are there, maybe virus are there, and after post-COVID, you are more conscious, and it is automatically. And your time in the OPD reduced drastically. And what else you need if your patients are going satisfied?
True.
So that is the thing I want to focus
on
and
the
actually
automated OPD.
Yeah.
Perfect. Samir, you have the last word, 30 seconds.
I know the pressure is on me between lunch. Well, I have only one word, which is vigilance. How do you want to maintain that vigilance? Define your indicators, your KPIs, whether it is financial ones, whether it is turnaround times, your outcomes, whatever. How do you compare them across? What are your benchmarks? Is it local, your own internal trends, international, national best practices? You want to settle up best practices. And third is your system has to be completely agile. How quickly do you respond to a changing environment? So probably we would have invested into a technology maybe 10 months back. If it requires an upgradation, have we planned or thought, and how do we, steer across? If it looks at partnerships, go ahead, do that. So that's my only mantra, is to keep yourself agile, know what you want to look at, and constantly monitor and measure your performance. That's how I think you'll be able to deliver operational efficiency.
Great. So
Thank
be
you.
agile and vigilant. Yes, you were mentioning something. One question, because we are running behind schedule.
I would like to take this question. Yeah, if you allow. If you put the empties everywhere, it is not possible, because the doctor knows what he has to write and what. So you have to train your doctor in such a manner that they do it. Because anyway, non-medicals cannot grab so fast until unless they have been provided the training and they remain in the same atmosphere for more than years and years. So training to the right person is the key.
Okay, thanks. So
So
any
a
more
lot of
questions?
HIs
we'll
also
take?
are voice enabled. So the latest one which you are doing, the doctor just has to tell blood pressure 120/50, this, and it automatically says. I even tested them that does it gets polluted with your noise background, and I would utter something nonsense so that it starts typing that. So one of the software does type it, but then most of them have addressed that they don't.
The scale has improved now, but still, any other question, we'll take it offline. So before we disperse from this panel, I would request Shangomitra Mohanty, co-founder and director of APAC News Network, to hand over a token of appreciation to all the panelists. So can we have the token? So we'll start with Upasana Arora. Saurabh Gupta. Dr. Kousar Shah. Dr. Mamta Jain. Dr. Samir Singh.